Good evening, everyone. Welcome to the second episode of the Dialogues on Primary Healthcare, which is an initiative by Center for Primary Healthcare at Basic Healthcare Services and Center for Healthcare at IIM Udaipur. Basic Healthcare Services is a not-for-profit organization driven by the vision of enabling marginalized and vulnerable communities lead a healthy life with dignity. Through a network of primary healthcare clinics, BHS provides healthcare to rural and tribal populations in the districts of Udaipur and Dungarpur in southern Rajasthan, India. And Center for Primary Healthcare, housed within BHS, aims to be a place that makes freely available knowledge, tools, trainings, and technology to design, implement, and evaluate primary healthcare services for the marginalized. Center for Healthcare at IIM Udaipur is envisaged as a global platform that brings together academicians and practitioners to enable scholarly, impactful, rigorous research using a management lens to promote the health and well-being of the rural Indian and other LMIC populations. The center works to generate and facilitate the use of knowledge to improve the health of the underserved and to be a catalyst for healthcare providers, decision makers, and researchers. And our joint initiative, Dialogues on Primary Healthcare, is a series of conversations with eminent people with deep experience of practicing, researching, and policymaking on different aspects of primary healthcare. The dialogues aim to initiate conversations and thinking on practice and policy of primary healthcare in India that are informed by evidence and experience. And we hope the series help draw attention and some action to the agenda of strong primary healthcare systems in the country. Our second episode today takes us all very close to the primary healthcare teams made of physicians, nurses, community health workers, and others who are really the core and the face of primary healthcare, and who together address the huge variety of needs of patients and communities. We would all have interacted with them and formed opinions about them. Today, let us hear from the work of our esteemed panelists, how the social and organizational factors and gender and power influence our providers and through them also the healthcare delivery. I'll pass over to my fellow moderator, Professor Niranjan.
Thank you, Dr. Sanjana. Just a quick self-introduction first. Dr. Sanjana Mohan is the co-founder and the director for nutrition at Basic Healthcare Services. She holds an MBBS and an MD in pediatrics from SMS Medical College, Jaipur, and a diploma in epidemiology from the London School of Hygiene and Tropical Medicine, University of London. I'm Niranjan Janardhanan. I'm an assistant professor in the management department at the London School of Economics. And I hold a PhD in management, and I'm pretty much an outsider looking into the healthcare sector from a management perspective. It's my privilege to introduce our experts and speakers for today, Professor Radhika Gore and Dr. Priya Das. Before I go into the details and before we get started, just as an icebreaker, we thought we will ask you as the audience a question and ask you if, based on your experience and your understanding of healthcare in India, do you think this is a myth or a fact? So, is this a genuine statement by a health worker? No one asks my name, not even by mistake. I see the responses trickling in. Perhaps give it another couple of minutes. Meanwhile, let me introduce Professor Radhika Gore. She is an assistant professor in the Department of Population Health at the NYU Grossman School of Medicine and is Director of Research at the Family Health Centers at NYU Langone. Her research focuses on social and organizational factors that affect healthcare service delivery and clinic-community relations. Her work examines doctors and nurses, their multiple roles, and the resources at their disposal, and also how they're perceived by their key stakeholders, which include several of us. She will talk to this question through her presentation. Let's have a look at the results. So as you can see, 32% thought that this was a myth and 68% thought this was real. Over to Radhika now to tell us whether this was real.
Thank you so much, Niranjan, and it's a pleasure and a delight to be here. Thanks for inviting me. And yes, we'll get to the bottom of this question of no one asked my name. So I will start sharing my screen. I have some slides. Yes, one moment. I hope everyone can see the screen. Yeah. Okay, so what I'm going to discuss today, present today, is share some ideas and findings from the research I did in India some years ago now. But I think that the lessons and the analysis I hope is something that we can take away to answer this question of how does the social context, social, political, organizational context in which healthcare providers operate, how does that affect healthcare quality and their performance? I'm going to talk about the challenges that primary care providers face and what I refer to as their dilemmas, and I'll discuss more about that in a second. So I just want to say that I wear two hats at NYU, and just want to say that the views and analysis I present are mine alone and not those of the family health centers at NYU. So this is a kind of a snapshot of everything that I will talk about, touch upon briefly throughout this presentation. I'm going to talk a little bit about the motivation for this study, the fact that there is widely known quality of care is poor, and that there is a no-do gap, and I'll discuss what that means. The research question that's motivated by that finding, which is that, how does the social context matter? How do political factors matter? The setting in which I conducted the study and tried to answer this question, which was in Pune, about 10 years ago now. Theory, just a quick highlights of conceptual lens that I used and which I think is really important to help us see how social and political factors might affect healthcare delivery. The methods I used, which were qualitative, ethnographic, and then my findings. And I'll highlight three themes from my findings. So that's in a snapshot what I will do today. So the motivation for this study, right? This is widely known, and the work of Jishnu Das and colleagues has been really instrumental for highlighting low quality of care in both public and private sector healthcare delivery, primary care delivery, particularly in India. And we know that there is a no-do gap. That is that if you test what a provider knows in terms of medical knowledge, or if you look at their credentials and degrees, that seems to be there, but that knowledge doesn't seem to translate to actions that actually deliver high quality care. And this table, just taken from one of their Das and colleagues publications that shows that when you use standardized patients, so these are sort of actors who are showing up with a certain prescribed, presenting with certain conditions, it's only in a fraction of cases that the doctor gives the correct diagnosis. And there is even a small number of cases where a diagnosis is given at all. Consultations are very short. Das and colleagues have found that in rural India, healthcare providers in public clinics spend only 3 minutes on average with a patient, which is a very short time to even arrive at a diagnosis. And yet, it seems that providers have credentials and have knowledge. So there is a gap between what they know to do and what they actually do. A lot of the next step that often comes from that recognition of the no-do gap is that we need to train providers better. We need to improve skills. They need mentorship. They need incentives to perform. And these are all critical inputs, certainly. But what it can miss, when we focus on those clinical behavioral factors, so focus on the individual provider, is we might miss that performance is actually context dependent. That is, it depends on the social and organizational context in which health systems operate more generally. This context in countries like India and other low and middle income countries is rife with challenges in multiple domains. So just three things these are the common challenges: weakly regulated health system, state investment that is not adequate to evolving needs, health needs, and changing population needs, and low societal trust, so low patient-provider trust, but also low general trust in the health system as an institution that is meant to serve the public. And all of this, weakly regulated care, inadequate state investment, low trust, occurring in an environment and contributing to an environment where the private sector, the market, dominates healthcare delivery. So it's certainly in India, it's just certainly a case where there's a mixed public-private system where the private sector plays a large share. Studies consistently show 70 to 80% of outpatient encounters happen in the private sector. So if we now focus on public sector healthcare providers, the question is, and we know that this no-do gap exists, the question is, how do they operate in this kind of environment? How does this general context, this environment of weak legal regulatory system, state investment, low trust, how does it affect what they do and their performance? That's the question that I sought to answer through this study. The setting where I did the work was in Pune, Maharashtra. This was 2013 to 2014. It was roughly a year and a half of fieldwork. And the study was conducted in municipal government clinics. The urban setting of my study is important to note. It's part of the social political context that we're referring to. So the findings from this work may not translate readily to rural settings, may not even translate to all other cities. But I think what we can get are the analytical insights from how to relate context to performance or to what happens at the micro level. But I do want to mention the urban setting, just to kind of give a glimpse of how this context matters, right? If you look at the health system in India and you look at it at the state level, how is care at various tiers organized? You generally have primary care in rural areas. So you have the health system under the Department of Health. Primary care is offered in rural areas. This is first contact care for a broad range of health conditions. Secondary care, people are referred to secondary care if the condition is complex, and then tertiary care in cities where for care that uses higher technology, and that's typically located in urban areas. But what you can see is that in urban areas, if you look at where is primary care in urban areas, in Maharashtra at least, it's organized such that it falls under the Department of Urban Development. So the doctors that I studied, the primary care doctors in Pune, in municipal government clinics, it's proceeding on its own, did not fall under the Department of Health, but rather the Department of Urban Development. So that's important to note because a lot of their resources and constraints stemmed from their position in the health system. And I can talk more about this, but just want to flag that this is where they're seated. We need a conceptual lens to understand. So given that they're in this context, how do we now start to view them? How do we start to view the provider in their environment? Just two things to note. Important to conceptualize healthcare provision, not as a transaction, but as a social act. So not just as an exchange of medical advice for affective or financial reward, but but to see this, that providers' decisions and actions are also driven by and motivated by the meanings, the subjective meanings they attach to their experiences and the relationships they have with others in the work that they do. Second conceptual move is it's important to see healthcare providers as what I call street-level bureaucrats, drawing from a massive literature in public administration, sociology, and political science. A street-level bureaucrat is a frontline worker who is interacting every day with people as they're providing public services. But they are the front lines of organizations, state organizations, that give them or sometimes do not provide them the resources the institutional processes, the policies, guidelines with which to do their work. Often in that role at the front lines, they face conflicts between what they're supposed to do in practice and the resources that they have to do them. And how they manage that conflict, how they manage what those dilemmas is really what results in what we measure as performance and quality. So it's important to understand that they play that role. And importantly for us, for these primary care doctors sitting in these government clinics, they are not only state agents, because they're working in state institutions, they're also medical professionals. And they wear both these hats simultaneously. And the decisions they make come from an intermingling of these two roles. So bear these two things in mind. The methods are used. I mentioned this already. Ethnographic. This photo is not from my site. It was in a newspaper article, but just want to bring us into that space. Busy clinics, multiple doctors sitting at a table. I would sit alongside them and observe, just sort of silently sit there with my notebook. Did that for about a year, and then also interviewed doctors and others in the health system to try and understand from them later on in interviews or wherever they had time to help me make sense of what I was seeing. So I'm not a clinician, I'm not a doctor myself. So my questions were not about their clinical diagnosis or treatment, it was really about the trying to understand socially and politically what was going on. Why did this happen? Why did that patient say that? And why did this other health system act or work? Why did they operate in that way? So trying to use the time I had in between these sort of sessions to get answers to those questions, make sense of what I was seeing. The importance of ethnography is that it allows you to see in real time what's actually happening and then ask questions about that. The advantage of that is rather than rely solely on interviews or surveys where you are asking questions after the fact, here you're in the room as it happens. And so now I'm going to talk about my findings and highlight just 3 themes. I'm going to talk about how the doctors experienced and responded to, and I'm bearing in mind the medical provision, healthcare provision as a social act, and these doctors wearing those 2 hats as street level bureaucrats. From that perspective, I'm going to examine how they experienced and responded to public opinion, the local political embeddedness of healthcare, and then their conceptions of medical risk when it came to treating patients. Okay, so let's start with public opinion. What is public opinion? Citizens' voice, citizens' power to voice perspectives, a very important part of how states work. It's important that citizens have an opportunity to voice what they feel. The public opinion is not always, writ large. It is often also expressed and experienced in everyday encounters with the state. And because municipal doctors are at the forefront, at the front lines of healthcare delivery, they not only every day encounter how citizens feel about the state, they also are then in a position where they have to do something about it. They have to respond. And in that role that they play, they routinely encounter public opinion. How do they experience it, and to what effect? What effect does it have on the care they provide, and what effect it has on the quality that, as we measure? That was what I tried. That was something I tried to discern. So how do they experience it? One doctor put it, patients from the provider's perspective, patients tend to see the healthcare that they receive in municipal clinics like the ration, like supposedly substandard rice in public ration shops. That's how a doctor felt that patients were regarding the care that they were providing. Now, neither of these photos is from my fieldwork, but I just juxtapose them here to show that from the doctor's perspective, patients lining up to receive care was sort of imbued with this idea that people were showing up to the government clinic as a last resort, and that made this encounter fraught from the start. The challenge this created for the doctor was that there was no way to change that public reputation, because you were battling a perception that patients had formed from outside the healthcare system. This was a perception about the state at large and the general ideas about welfare bureaucracy that patients held as they came to the healthcare clinic. And for the individual doctor now confronting this large weight of public opinion, it was very difficult to change. Doctors also felt that patients had a lot of misinformation about the kind of care that they provided. So one doctor shared with me a story about vaccines, that, vaccines come in 10-dose vials and you can't open a new one each time a patient comes in for a vaccination. But that was what patients expected. And private providers would do this, but they didn't do this in the public sector, and that harmed, it just created misperception about what providers were doing. Even when doctors acknowledged that people preferred private providers because they were more personable, more responsive to patients, this did not always mean better care. So sweet talk doesn't always mean better care. And doctors, again, these are municipal doctors in the clinics, felt that patients, again, had a misunderstanding, a misperception of what was good quality healthcare. And that, again, undermined their own work. So you had a situation then where you can imagine the patient-provider interaction, even before the encounter, is already weighed down by these ideas, this public imagination of what the patient thinks they're getting, or they're receiving, and what the doctor thinks they are providing, and to whom they are providing. So doctors were not always personable and responsive. This is also something that I observed. Patients held a low opinion, and doctors perceived patients as intractable. And this made for an unfavorable expectations of the encounter from both sides. So public opinion showed up in these frontline encounters to kind of undermine from the start what that encounter would be like. Just hold that thought. I'm just going to talk about political embeddedness, the other two quickly. So political embeddedness, the municipal clinic, as being part of the state system, is embedded in the local political dynamics of electoral logic, as well as the administrative system. That's important to recognize. And that, again, shows up in everyday work that the public sector provider in these clinics, that the doctor has to do. Here, I want to draw attention to the fact that not all of these operations, not all of the things that happened are outright acts of corruption or misuse of power. And there's something more subtle and nuanced happening, which is what we might call a deviation from public integrity. So there are actions that happen that are within the law. They're not a pursuit of private gain, not a misuse of power, but yet do not promote the public good. And those acts are deviations from integrity that the doctors experienced every day and had to, again, respond to every day. They experienced these in terms of directives or instructions from political and administrative authorities that they could not refuse, but that also did not really promote the worth of the value of their work as medical professionals. So here again, you see this dual role, medical professional, state agent, and then having to respond to a system which does not always seem to uphold public integrity. How did they experience this? Just one example. I was sitting at a clinic that the doctor pointed out to me a man standing near the door of the consultation room. He was sort of unshaven, disheveled, and she said, he's an employee, and his job is to sweep and keep the clinic clean, but he hardly did anything. He was an alcoholic, and he had been posted there because of patronage relations, and he could not be removed. And when the doctor had asked the administrators, what do you want me to do with this person? He doesn't do any work. They said, just take care of it. So her response was, well, so that's what I do. We just take care of it. We just let it be. And these kinds of this was a kind of insight into what the organizational constraint was in that case, that doctors just simply had to respond and accommodate in their everyday work. And I write about more examples of this as well. Why does this matter? Because doctors are now, through incidents like this, implicated in electoral logic, right? So we see them as removed from political dynamics, but actually that those politics interfere in they disrupt their everyday work. So other examples, they had to be lenient. So this was an example, they had to be lenient with support staff, they had to accept job transfers, they had to ensure that some patients were seen before others, jumping the line, or they had to just accommodate managerial shortfalls. And in response, doctors restrained their practice. So as one said, they would just do enough just to ensure the ordinary. So this is now starting to get to, the no-do gap. Finally, medical risk. Very quickly, uncertainty is inherent to medicine. Doctors are continually making decisions about how to treat a patient, how to act on a medical case, how to anticipate patients' responses, and don't always have resources to help them to manage this uncertainty. Certainly, the municipal doctors in Pune did not have resources. Information, education, mentorship were all lacking. A legal regulatory system also weak. And so one of the things I found was that when it came to non-communicable diseases, doctors simply didn't treat patients. They often just referred patients. So commonly, hypertension and diabetes were not treated. I see a hand raised. Is there a question, or should I just keep going? I'm 2 minutes done. And when asked about why they didn't do this, again, we're trying to place the provider in the context of his or her larger operating environment. They describe factors in two domains, going back again to this dual role that they have: medical professional and a government and a state employee, state agent. They said that they were not competent to treat non-communicable diseases. They felt that a higher credentialed provider was better suited. And they interpreted the municipal mandate as to exclude non-communicable diseases, even though these frontline care for these diseases is included in policy. So they just interpreted their mandate, no, we don't want. And why? Why were they making these very constrained, restrained interpretations? Because they feared the socio-political consequences of treating a patient and having something go wrong. So in situations where medical decisions, medical actions are inherently uncertain, the challenge of taking on, of actually providing care and being subject to these sorts of consequences in a weakly regulated environment was something that doctors were trying to avoid. So what they eventually did, the way they understood and explained their decision not to treat, was that they felt this was doing less was better for themselves to avoid these kinds of sociopolitical consequences, and better for society. So you find here that doctors are in sort of subverting, making themselves smaller than they actually could be. My final thoughts on this, I sort of just a glimpse into how social and political factors and the environment, the context can affect what doctors do, what they say, and why, how they explain their performance. And reforms targeted to skills and incentives alone may not shift this, right? So these are just some questions. These are not prescriptions, but just questions that I hope we can think about, that along with medical training and improvement in skills, we also need to empower doctors, right? So that they're not self-sabotaging in a way. Build upon their altruistic and their community orientation. You need managerial training. You also need empathy towards patients. Legal regulatory reform, really big one. And then performance incentives, maybe not at the level of the provider, but maybe at the level of the healthcare facility. That's just another idea and something to think about. But that's what I have. I will leave it there. And thank you very much again.
Thank you so much, Radhika. It was very insightful and very food for thought for all of us in terms of thinking about healthcare in urban centers. Just a reminder for the participants, please pose your questions in the Q&A for our experts to answer them. We will not have time for verbal questions during the session. So without further ado, I'm going to launch the next poll. By now, you're familiar with what this is. So is this a myth or a fact? Again, a statement by a health worker. Being women, they lack the strong will and determination. If they had that kind of determination like men do, they would have been able to perform despite the constraints. So while Dr. Priya will be able to answer this, very quick introduction. Dr. Priya Das is a principal consultant for gender and health and is the gender focal point for Oxford Policy Management. She has worked as a senior research and gender specialist at the International Center for Research on Women, Asia Regional Office. Her work involves ethnographic research as well in health facilities and innovative methodologies to understand time use by auxiliary nurse midwives and women's leadership in healthcare projects to integrate gender responsiveness in health system strengthening initiatives. All right, so we have a 50-50 response on this question. So is it a myth or a fact? Over to you, Dr. Priyadas.
All right, good evening, and thank you so much. It's a pleasure to be here. Thank you, BHS and IMU. I'm just going to start sharing my screen in a second, I think. Can you all see my screen now? Yes?
Yes.
Okay. Good. Okay, so good evening once again. And my presentation is not really, the 15 minutes is not really structured through the presentation, but I'm going to use slides intermittently to take us through what I have to share and discuss today. So the primary question that I'm answering here today in this thing is, how do gender norms as a socio-cultural norm shape the technical and clinical work of a particular category of providers within primary healthcare settings? All of us, I'm sure, in the audience is familiar with the fact that 80% of the global health workforce are women, right? And the provider that I will be focusing on today are women healthcare providers, particularly nurses and ANMs in a primary healthcare setting. We all know that in India, ANMs and nurses are critical to the provision of sexual and reproductive health. And a lot of research that we read around their performance often attribute non-performance to their own individual capabilities or to the systemic constraint. Despite emerging evidence on gender-based discrimination, we still don't, and low professional acceptance, we still don't see make a link between the constraint to power asymmetries within the health systems. For those of us who have practiced or researched in health systems, we are very well aware of the fact that, like all other systems, health spaces, health facilities are social spaces, right? And they entrench and reinforce the same existing social norms that exist in the society in which these facilities operate in. And that goes for gender norms and inequalities. But in this case, the norms that operate in the everyday functioning of health facility actually have adverse impacts for the female workforce and the quality of service they deliver. And to just, I'm going to use a slide to say that the gender structure, it's not an organizational culture or an environmental culture in isolation. What plays out in terms of the gender dynamics in a primary healthcare level, actually, to move to the next slide, is something that is structurally embedded in the way the health systems are organized. Very recently, using secondary literature and key expert interviews, we tried to map the gender inequities that exist within the health system at a systemic level. And we use the WHO framework of the building blocks, which is often used for health system strengthening initiative, to look at how structurally inequities are embedded, right? So we look at the first pillar here, human resources, for instance, right? Which is, we see occupational segregation. We see this cadre always at the lowest rung of the system, at what salaries they get in. We see pre and in-service education of low quality. Career growth is one of the biggest problem that and we don't have, despite I think many years of talking about career, the lack of opportunity for career growth, it continues. We see workplace violence, which we never talk about. Similarly, I mean, now I think everybody's aware it's existed forever, but I think we are doing much more work and hearing much more. The huge deficit of leadership of women in the health system. There's poor management and governance in general, but also particularly of the female-dominated cadres. in terms of financing, we see gender pay gaps, we see casualization of labor, we see poor access to information and technology, we see poor capacity building on, there's so much digitalization going on right now. And yet we see poor access and capacity sort of strengthening around that area. And also in terms of information and documentation, not only do we find structurally less access for this cadre, but we also see them bearing this huge burden of documentation, which I will talk about a little bit in my presentation. And the reason I start with this particular slide is an attempt to really connect the structural with the individual, the structural with the organizational, to understand how gender really plays out on an everyday basis within the primary health care. So what am I presenting? The key findings that I'm presenting today are from an ethnographic research that was part of a much larger evaluation that OPM was involved in terms of a health systems initiative. The study was done in 2 community health centers in a rural setting, in a low resource setting context in India. The study was, it was quite difficult, as I realized, to do ethnographic research in real time in health facilities. So it took a lot, but we did this over 8 months under multiple rounds of immersive study. And also just to set a little bit of the context, because it will appear in the slides that I present. In this particular state, because of the acute shortage of general nurse midwives, ANMs who are originally outreach workers got trained and got inducted to do the roles of GNMs. Some of them were permanently posted in these facilities, and some and served as the same sort of provided the same services as GNMs, but others also did the same service plus outreach work. So that when I refer to ANMs, I mean both ANMs and nurses in many of the slides that I present. So let me move on to, so what did we do what was the context of this, very much like Radhika's? The purpose of the main intention of this ethnographic study that we did was to really understand the no-do gaps. So now, because of the low resource sort of capacity and strength, there were a lot of clinical and technical training happening for the nurses and ANMs. And what the question that I went in with was to understand, why is it that the training that the ANMs and nurses receive, they seem to know how to do it, but never do. So when they're observed in practice, they don't seem to do it, but when they were tested on the knowledge score, it was very high. So the point was to go in to explain this no-do gap that existed. And what we did to, and we didn't start out with a gender lens, to be honest. We started to understand, so how does an everyday facility work? Who are the different actors? What are the interaction, the relational dynamics, the street level bureaucracy that happens on a daily basis, to work in a very resource constrained kind of setting, right? And often the reason it became quite apparent because the no-do gap was often termed, quote unquote, as underperformance. They know, but they don't do. They are being lazy about this. And so to really unpack it, we analyzed the ethnographic data using expression of power framework to understand where do this cadre of women health providers really stand using this thing. And what we found was that gender determines it starts with the slide that I shared, right? That the structural location of women and men in the health labor force. The gender biases influence how work is recognized, valued, and supported, and has differential consequence in terms of career trajectory, pay, training, and other sort of technical resources, right? And we found that these structural inequities at the low level are sort of, are embedded in the formally sanctioned hierarchical power, right from top to down of the management structure. And overwhelmingly, what we saw very often, what we called lazy work, underperformance, I'm seeing all of you, so maybe my screen, okay, got it. So what all of this resulted in was the micro practices or the manner of actions and failure to act, which was what I said was not doing their work. And what this was about is really, only working on the essentials, often performing out, all of which I'll explain in a bit, insufficient time and incentive to undertake mentoring activities, high absenteeism, what we call petty corruption or goodwill money, as it was put in the context. And yet with all of this operating, we expected the SCADA to deliver respectful maternity care and deliver quality of care, right? Which is what was why we were doing this whole no-do gap work. And in terms of this expression of power, what we really found that we find that the ANMs and nurses' low position within the official hierarchy allowed managers and doctors to have excessive power over them, and that severely curtailed their expression of all other forms of power, right? So deeply entrenched patriarchal norms, very much like in other Indian states, um, they accorded very sort of low social value with weak access and resources and opportunities for the cadres, right? They occupy the lowest rung of the hierarchy of clinical providers. And ANMs, throughout both the nurses and ANMs, we saw a very subservient engagement with any, and that was not equally, there were no male nurses, but for the lab operators, etc., the subservience was official, but with the ANM and nurses, we kind of was highly subservient. And, it kind of reflect what Bourdieu often puts as the gender habitus, right? So the facility becomes a repository of the symbolic forms of the structure, as well as an internalization of the social structure. So the nurses, like in another paper that I've written, is often said that we are nurses, so what can we do, right? So as and we know from literature, so they're not socialized really to exert power in that sense, and that's where they really sort of stood in this framework. And so, what does this low level of power meant for them? It leads to the lack of access and control over resources and condition on which they have to perform, especially if they are accountable to it. And since they had no control over the condition or resources, this often led to all kinds of frustrations and failures, right? Which is what we see here in terms of the adverse and perverse kind of micro practices that they engaged in. And let me just take you to what I mean what it really meant when I say that lack of autonomy or decision-making over the work and the conditions they had to do. So we kind of try to map how does a nurse or an ANM in the labor room or in the facility posted for the full day, what does a work shift look like? And it's completely, they manage an unrealistic amount of workload, right? They lack control over the work you designate to them, and they're supposed to work across multiple competing program priorities in one shift, right? And they are accountable for each of this work that they have to do, and should they not be able to, so if one is posted in the labor room and there's a family planning operation going on and she's expected to be there as well, and if the delivery happens in the ANC, not even in the labor room, the primary person held accountable for will be this particular nurse who was meant to be in the labor room but has been called to the family, and she can say no to, she can't say no to either of that. And not only was this entire power hierarchy operating in terms of what they could or couldn't do, but even the spaces within the facilities were gendered, right? I mean, I just sort of, I put out a slide to see how it operated, right? So she says, when rooms were being allotted, all the men occupied all the rooms first, including the management. It could be a BHM who's not supposed to have a room, and that was the room was given because he was a man, and that resulted even the ANMs not even getting their restrooms, right? So where they can be, what they can use, remain completely gendered, right? And in terms of, sorry, I'm just running ahead of my thing. And what does it mean? And the most important thing that I think we was the most sort of impacting the way they could or could not perform was this what the management theories really call the multiple accountability disorder, a very appropriate acronym for MAD, because their accountability was literally mad. They had A&Ms had multiple reporting lines, formal, assumed, and intervention-based, and are held accountable by all levels of official, whether it's district, and they have multiple meetings, weekly, monthly, and they are also answerable for the non-achievement of several numerable targets. And because of the relational power dynamics within, they had multiple levels of informal accountability, because we, as some of us may know, there are all the monthly district meetings, there are expected level of achievements in which they have to report, right? Which is the chief sort of in charge of these facilities. But the burden of that also fell on the A&Ms and nurses, because 80% of the services provided by this primary healthcare centers were around reproductive health, right? So when they are subjected to this high levels of informal accountability, they end up what quote unquote performing out. That is maintaining the projection of performance of the facility and maintaining the right document, which often meant falsifying data and process, right? And as an A&M in the facility, it's kind of shared, right? She said, what could we do? We cannot leave the job. If the office is always asking for information in the right time and the right way, we have to provide all of this, we have to quit eating and drinking. And they want to see filled paperwork. We do it that way. How many work they give us, we must find out a right way, right? So that we often saw very sort of the photographs before, because we were there in real time making observations in the real time. We were seeing what documents were being made, and the most primary of them were a multiple number of false photographs, which is used as a mechanism to review the performance and also sort of check the quality of delivery of services, right? So in a situation in which A&Ms work within systemic binding constraint, receive poor management, have little control over factors required to perform effectively, and experience high and punitive accountability, these completed documents or false photographs, they become like social tools by which A&Ms safeguard themselves against allegation of medical negligence and protect their instance, right? And despite all of this, what we find, which is fundamentally seen across sectors for gender, is the lack of recognition. So what we found is that we start off with an A&M who's only meant to do outreach. Then we post them in the facility, train them to do the GNM's role as well. And then we say, okay, you do this plus outreach, but just want to take, and nothing changes for them. And I just want to take you to part of this quote where she says, even if we learn and adopt new practices that are being taught, we do not get any career jump from learning anything new. Working in labor room impacts us negatively as everyone holds us accountable without appreciating what we do. We were recruited as A&Ms and we will retire as one. So there is clearly a lack of recognition of what they can. And as we started off with the quote in this session, right? So we found that managers and supervisors often took advantage of the low social and political and cultural capital women had within the facility and blamed them for made gendered assumptions about their capabilities, right? So we were so when we said, oh, there's too much workload, how do they manage so many sort of kinds of tasks within the same shift? This was what we heard back, right? Being women, they lacked the willingness to perform with integrity. If nurses had been men, they would have delivered even under constraint. And the whole idea of lazy, oh, they are women when they get together. So a lot of very gender stereotyping of what was actually their real constraints and compulsions for not being able to deliver what they were meant to deliver. And so with this, I just want to end by sort of focusing on how important really it is to focus on understanding how these dynamics operate within health systems, right? Because much of the work, and I've been now sort of working on this issue for a while, when we talk about gender in health system, it's largely client facing, right? It's about the quality of service, their reproductive rights. It's about respectful maternity care, etc. But there's very little work addressing the gendered factors that really impact the health provider performance. And I'm of the firm belief that without confronting and addressing these power dynamics and the inequalities that are structural in nature, trying to create a conducive environment for healthcare provision will remain completely sort of elusive. And to conclude, I just want to say very often, even towards the preparation of this, we were thinking of solution. And very often I'm asked, why focus on the problems and not solution? Okay, gender is a problem, but what's the solution? But I do want to end by saying that gender at heart or essentially is about power. It is about power relations and dynamic. And since relinquishing power, as we all know, is very, very challenging, any solution must address existing gender norms and biases that are embedded in management, supervision, accountability for any sort of lasting change. But this does not mean that we start, sort of creating initiative to work on social norm change. I think the strategy is to really, looking at what is it that, what is required, what roles they can occupy and how that can be facilitated, right? So it's enabling better access to resources for these cadres, safeguarding the rights and interests, taking sexual exploitation and abuse in the health system, of which we never speak about, establishing proper grievance channels and redressal, having reciprocal accountability and supervision system as part of the health systems. It's also having distributive leadership. And I think all of these things will really be possible if we first and foremost acknowledge that gender dynamics do impact the way cadres can actually provide clinical and technical service. And I'll just end there. Thank you.
Thank you so much, Dr. Priya. Again, very insightful and lots of food for thought. Let me start off with one question sort of aimed at both of you, given your rich experience in this domain, and then I'll hand it over to Sanjana to handle some of the questions on the chat as well. And please feel free to answer to the questions directly if you feel it's a quick answer. So my question is, given the nature of the issues that you're talking about in terms of power, so the lack of resources, both from a gender perspective as well as generally from the perspective of being in potentially cash-strapped, low resource availability contexts, how do you see the private arm sort of playing in here? So in terms of the partnerships, have you seen best practices somewhere in terms of how private players or even citizens could contribute to this situation and potentially help alleviate some of these concerns?
Radhika, do you want to go first?
No, go ahead.
It's not just about private. I mean, yes, not because BHS is organizing this, but I have seen good practice in the Amrit clinics, for instance, right? That actually fundamentally centered its last mile service of primary care, centered it around understanding what it means to be gender responsive for this cadre, right? And it meant safety, security. It also most fundamentally meant actually enabling them to lead these primary care facilities. I have done the field work there and I've met these people, and I'll just give one line which says, which kind of tells you what the shift is, right? And when we asked, wow, what's the difference, right? You are a A&M and you've been, and they recruit privately. These are not government A&Ms, right? And I think one thing they told me, so which stuck in my head, is that, often when we worked with other private facilities as A&Ms, I was told, go to that cupboard, pull out that blue box and bring it here, and that's it. But here, I know what is in that blue box. I know what it needs to be used for, and I will administer it, because they only were run by A&Ms and had doctors on call for a week. So there is the idea is whether it's private or public, right? It is about really recognizing the potential, and it is about giving the rights and entitlements and sort of looking, making the system much more gender responsive. And there are many more practices and within the private, even within the government systems. We did a program review, and there was a very interesting practice where, of course, within the systems constraint, with this resource constraint, the micro practices within the facility, like in this place, when the nurses came in, they asked them about their well-being. They created these small sort of breastfeeding corners. They just gave a routine checkup of health by the doctors, right? They were still under the same system, but recognizing and creating this micro practices made a difference. And I'll stop there.
Yeah, I'll just, this may not directly answer the question, but I think the private sector, at least in the context of primary care provision and in sort of large cities like Pune, really play a role in shaping how people perceive of good quality healthcare, what it should be. And in that sense, that dynamic does happen. I mean, we typically think of the private sector as taking a share of healthcare. In terms, we think of it as a market and a division of the pie. But alongside that distributional impact, there's also this affective, symbolic impact that marketized or commercialized healthcare can have on what providers do and how patients think about healthcare. So, I think addressing some of those structural factors in the realm of what we do, I think paying attention to how that dynamic works is important. But as for how to do that, I would invite your comments and thoughts as well.
Maybe I'll come in with some of the questions that have come in the chat box. So Priya, there is one question. There are several for you. I'll read out one. There's this question that will that change when nurses get an opportunity to be upgraded to a community health officer of a sub-center, bringing doctor level recognition.
You're muted. Yeah.
I don't think I have a definitive answer for you there, because this is a very new initiative, right? In fact, many of the A&Ms who've taken the exams have actually become CHOs. But it is definitely a career growth for them. But what remains to be really seen for this health and wellness centers is the structural factors going to change, right? Are they going to get equal pay, right? Are there safety and security going to be taken care of? Are they going to be immune to, sexual exploitation or abuse in their workplaces? So I think that it is a great opportunity for the next level, and the A&Ms I've met on the field have been very gung-ho about making it to becoming a CHO, but it does not mean that the dynamics that I just kind of discussed will go away because they are just CHOs. So I don't know how a male CHO will be treated versus a female CHO, for instance. Are they going to be looked at less capable than a male? Will a male be called a doctor, and will the CHO will always be called a nurse? So yeah, I think it's a good question, and I think it leaves a lot of space to sort of go and explore and understand this better.
Sure, thanks, Priya. There's one related question, and let's put that out. Did you witness any cases of sexual harassment of the A&Ms in your study?
I didn't witness. These things are not necessarily witnessed. But yes, we had many such stories. And also in the more recent sort of work that we done, from which I presented the structural inequities, we've interviewed many experts, some of them nurse practitioners, and they've told us many such cases. And they've also told us what was disheartening, and we've seen how the whole POSH Act and the lag in information collection, reporting, etc. But I think what I went away with is that often when you report, the burden of it lies with the nurses. They're given two options. One is either you quit and we give you a great recommendation, or you just keep quiet about it. So I don't think this, and I think you might really, I don't know whose question because I can't see my chat, sorry. But you might gain a lot of insight from this recent publication by Women in Global Health Initiative, that did that kind of did a poll across the globe and has brought out a report on how sexual exploitation and abuse in health work sort of manifests and is dealt with.
It's quite a heartbreaking answer, Priya. Yeah. A question for you, Radhika. You've answered most of them. Yeah. So, what difference would you see between GPs in family clinic in New York and municipal doctors in Pune? And what explains the differences?
Yeah, great question. I'd love to do a comparative study. I mean, the most obvious thing is that they operate in very different health systems that are financed very differently, that have different histories, and so that is a big part of it. But if I had to draw anything that's similar, I mean, they're private, they are primary care providers. They see patients as sort of first contact care, and the challenges of doing a lot in a short time that remains. So it's a good question. I wish I had more time to explore it, but I think context matters. I think that's a short answer.
Sure. Thanks, Radhika. Yeah. And there is this one more question. Is public-private partnership in health and wellness centers a solution? And this could be answered, Radhika or Priya.
Right.
Yeah, no, I mean, certainly I think there are things to learn about improving managerial efficiency and effectiveness. I mean, as I said, one lesson that I've learned, at least in the US, is that maybe incentives that are structured at the facility level rather than at the individual level might help to change norms, at least organizational norms within the system. And if public-private partnerships could be one way to start to think about how we can evaluate that performance, then there could be some scope there.
So I have a little bit of a layered answer for this, right? So whether we like it or not, in India, there's a very high dependence on private sector. And when we say private sector, I would be careful to say that it's not a homogeneous group. We're not talking about the big corporates, right? It's all kinds of private practitioners. And yes, it's extremely important, this partnership, and, PMJ and, the health and wellness, the logic behind is to really fill in the gap of the public health sector in terms of reach and facilities, etc. And so, yes, it's a great move. But having said that, I think it's really, really important in terms of how this partnership is regulated and monitored. Because in my understanding, in rural India particularly, right, private health practice can also embed some very undesirable practices, right? Many times, like Radhika had mentioned, sometimes the private sector kind of sets the standards for what's good quality services. And that has had so just to give, for example, in the private practice, Utrotonics is used unindicated, right? So the community began to understand that the use of Utrotonics to induce labor is a good practice. And so they would come and harangue the facility nurses that, why are you not doing this? You're not providing me quality service. This is what we get in the private sector. So yes, it's a need that is being met. It has great potential, but I would just be cautious about how it's regulated and moves forward. Yeah.
Sure. Thank you, Priya and Radhika. Okay, maybe just one more question. The question is, according to you, if we are asked to replicate the Amrit model in public health system, what could be the challenges when it comes to monitoring and evaluation on a larger scale in the health system?
Question for me? I think it's best answered by you, Sanjana. But to say that it can be, so, not just in health, right? As a gender practitioner, I practice across sectors. It When something goes to scale, right? When you're thinking about resourcing, when you're thinking about financing, when you're thinking about capacity building, when you're thinking about quality, right? You can't take something to scale. A lot of these factors just fall through the gaps, right? And we've seen it across programs when they are scaled, because initiatives like Amrit Clinic or others actually are very, very intense in the kind of inputs that go in, the kind of hand-holding that go in, the kind of capacity building that go in. So I don't think there's a straight answer to this. Yes, it can be scaled up. There is political will, there is finance, there's interest. But I think what can be scaled up is some of the practices that have been instituted, right? Like the they have these protocols of training for ANMs that really kind of help them move the next level of how they operate. So some of those things can be definitely scaled up, but I wouldn't say, oh, let's scale this up, because I think there are many, it operates at a smaller scale. And when we talk about scaling up, we are talking about multiple settings. So I would be cautious there to say yes.
Sure, that's very helpful. Thanks, Priya. So, Ninja, any other question would you like to ask?
Sure. So let me try and pull together some of the comments that came, and also question based on what both of you have been emphasizing here. So for instance, one of the question is asking about the continuous impact evaluation dashboard. And one of the directions that a lot of private healthcare systems, and including in India, have sort of taken is this idea of professionalization, where some of the roles that Radhika, you were talking about as these individuals who are engaged in healthcare provision are also playing the role of state agents. A lot of these professionalization initiatives sometimes tend to address some of these role sort of overloads in some ways by distributing those responsibilities across to others. And what that also does is of course, it comes with its own disadvantage of distributing resources in an inequitable way, which could affect, again, gender dynamics and so on. So where do you see the professionalization aspect coming in here? So are there any low-hanging fruits, in other words?
I'll just take a stab at this. So I maybe just also to clarify, I think these dual roles that I mentioned, and I think that in the public sector, healthcare providers will inevitably wear those two roles. I think it's very important that they are state agents, and that role should not be diminished, in the sense that the idea that the care that they're providing is meant to be available to everyone. It's meant to be for the public good. It's meant to be accessible, affordable. That comes along with the norms and the mission of what a state healthcare facility should do and should be about. So even as we professionalize, that is improving the quality of their training, the skills, the evaluation, management, I think it has to sit alongside this idea that what they're doing is for the public good. So, I mean, I'm not sure if I'm really directly answering your question, but I think what I'm trying to say is that the idea is that these two hats one doesn't overload the other. It's not an extra set of responsibilities. It's really it's a way of approaching the same issue, that you treat the patient as part of, we're all in this together. It's a collective public good. And so that shouldn't disrupt any professionalization endeavor, shouldn't disrupt that role and that orientation to the work.
Mm-hmm.
Right. So I think we are coming to the end of the session, and what a great session it's been. I'll just request all, Radhika, Priya, and Ninja for one, final takeaway from your side.
I can share something. First, I just want to thank everyone again for listening in. Just also to respond to the questions. Thanks for the questions as well. I think some of the questions really reflect the fact that the kind of study that I did and that are done in this way, studies that are done this way, need to be redone every few years. I think what my project certainly deserves is a revisit to see what has changed. So it's been 10 years under socioeconomic change in the city, under urban development, under different political regimes. How do these effects on the ground really play out? So I'm hoping that to better answer some of the questions I proposed today, I think I'm hoping to do a revisit, and I'm hoping to share insights again.
Great.
This is just to highlight the fact that this is always a dynamic and a continually evolving situation.
Radhika, one place where you are really very, very welcome.
Okay. Thank you.
Yeah. Priya, you're muted.
I think the one thing that I'm taking away from participating in hearing and answering questions is the need to really unpack this private-public partnership using similar lenses, right? Because we either look at private or we look at public, because in the place that I did the work, the boundaries were pretty blurred, right? Within 3 kilometers of any public health facilities, you will find a bunch of private practices, right? And not to say they are bad or good, but I think increasingly as India is moving to this kind of Ayushman Bharat and PMJ, it becomes more and more important to really take the kind of lens that Radhika takes, or the kind of lens that I've taken, to unpacking what really happens on the ground with this. Yeah. Thanks.
Thanks, Priya. Ninja.
Thank you. I think it's great talks. Thank you for this opportunity to moderate this session, actually. And I think for me, the takeaway is that heterogeneity. I think that Priya was mentioning directly, and sort of this complexity of the fact that obviously, given the size of the country and given the fact that the rural urban centers could look very different, how could different centers sort of learn from each other? I think that's the key in terms of going forward, in terms of if something works well with a particular sort of setup in a resource-constrained context, how do we translate that and transfer that to a different context? I think that would be the key questions in the next steps.
Yeah. Thanks, Ninja. Yeah. So I was just thinking some notes. I think there are some quotes that I'm just going to, carry on with me. That a doctor-patient interaction is not a transaction, it is a social act. To also be remembering the dual roles as a practitioner and a state agent. And that the health spaces are social spaces. And this concept of power over. I think these are some things that I will be remembering. And thank you both for helping us see that, so much goes into a health service delivery. It is not just a transaction. There is public opinion, there is political embeddedness, there is the medical risk, gender, power, all of these. I think we will all be going out of the session with these learnings. I think it's also symbolic that we have the International Day of the Midwives day after tomorrow. So to, remember them especially. And we hope that we are able to do our bit, all the audience and us as researchers, as working at policy, and even in our dealings with them, not see the doctors and the nurses as standalone, but as part of a system. And for us, Center for Healthcare and BHS, we are embarking on a big project with ICMR that looks at strengthening the health and wellness centers. So the discussions today are really very, very important. We will be mulling over them and we will be bothering you again. And in our bid to, finally get to a state that where we not just ensure the ordinary, but go much, much beyond it. Thank you so much.
Thank you.
Thank
you so much.
Thank you.
Thanks, everyone. Thanks for joining.
Pleasure.
Thanks. Bye.
Bye.
Bye.